Thank you very much. Thank you very much to Raed and our audience about the very nice subject about CTO. Chronic total occlusion is a challenge, either by the outcome of the patient with the CTO, with coronary artery disease, and how to manage patient with the CTO. What is the technique which we use, antegrade or retrograde, to open of the coronary artery. And our chairman is Raed, is pioneer in the CTO, and is very active to open the arteries in the CTO. So Raed. So many challenges of the patient when use, or the operator to use the wires and the type of the wires and type of the catheter and the guide catheter and the other thing to open the artery. This is a challenge. So we hope to see and show any new procedure for the opening artery, especially of the CTO and the division of CTO.
I think we are ready right now. Dr. Amr El Hadidy, we have the honor actually to have you. He's well-known expert in CTO in the region, so we hope that you will enjoy his talk. Please, Amr.
Thank you for this introduction to Raed and Dr. Mahmoud. I'm very happy to be here for the second time, and I hope that this meeting will end successfully as usual. My talk today about retrograde techniques, step by step. So if you do any coronary angiogram, you need to evaluate the CTO. There is no ad hoc CTO PCI. It means that you don't do the same session, the CTO procedure. You need to have a time to study, to have dual injection, to have studying the CTO segment, make a plan, retro or antegrade. So the most important point that we know about the general CTO PCI approach about antegrade or retrograde, either retrograde wire escalation or reverse card. This is the main 10 points that you need to know before you're doing any retrograde case. First, you need to decide this case is for retrograde, so you can go. And then you need to select the collaterals, either epicardial, septal, or graft. And then when you reach the collaterals, you need to choose the guide wire, the microcaster, and then to confirm this guide wire in the true lumen or not. And then you need to cross the collaterals with a microcaster. Then you decide how to do with the CTO segment, and then wire externalization, and then you remove the externalized guide wire. Okay, very nice. So this is an example of a case of a CTO RCA, and it shows that there is collaterals coming from the LED to this CTO RCA. So we need to decide where to go. If you want to go retrograde, you need to decide. And this is all we know, that the Japanese CTO score is well known for all of us, and that how to do to have this difficult case or moderate case, and then you need to see. This, if you look in this case, for example, this you need to study the lesion. First, if the cap stump is proximal or distal, the lesion length, the bends, calcification, or any branches before or after the occlusion, and the distal vessels and the collaterals. So it's very important to decide what to do in this case. So if you see that, for example, this case is a long CTO segment, calcification, and the lesion length is more than 20 millimeters, so this Japanese CTO score is 3. And all we know about this hybrid CTO crossing algorithm. If you look 4 points, very important 4 points. The first is to do dual injection, to look for the cap, is ambiguous proximal cap with poor distal target and the good collaterals. So this case can be used for retrograde. And all this is the new global CTO crossing algorithm from different centers. And one of the most important points, when you fail Antegrade at a time, you need to go look for retrograde. Sometimes you need to start from the retrograde, I know, but in some cases, and most of the cases, if you fail Antegrade, you can go retrograde. So in this case, for example, we, after trial of Antegrade wire escalation and then fail to cross with the wires, even with wire escalation, and don't exceed the cracks, because if you are crossing the branches, it will be a big problem that you can close one of these big RCA branches. So you need to look and decide. Now we are looking for the collaterals. In this case, for example, if you look the any collaterals, you need to know the type, the septal, epicardial, or grafts, and you can look for the size. The Werner classification about the sizing of these collaterals, small or bigger collaterals, and the tortuosity and the dominance of these collaterals. And this is the optimal septal collaterals as we see, and definitely we don't want to go for epicardial collaterals. The point is, when you're looking for epicardial collaterals, this is the most dangerous, more risk of perforation, and definitely the septal one is the best collaterals, or the graft for less complications and easy to cross and not tortuous like the epicardial one. So if you need to succeed, you need to choose a big collaterals and the more straight one to help you to succeed. So these are the J channel score. Also, when you have more bend, you have more continuous bends or corkscrew bends, so it will be difficult to cross the collaterals. And if you look in this case, as we see, very important to look for the collaterals. In this case, we have a epicardial one coming from the diagonal branch to the distal RCA. And this diagonal branch, you can test it by tip injection from the microcatheter. It's very helpful to go with the retrograde wire. And then you need, when you reach the collaterals, how to reach the collaterals, you need for the usual workhorse wire, that can, for example, cyan blue or whatever wire you like, you have a bend in this wire to catch the collaterals or septal collaterals, and this is very important to start, and then you push the microcatheter behind, and then you can change this wire again to go for a retrograde wire. So these, how to cross the collateral, we know that you have septal surfing. Septal surfing is a very good to try to go through the septal collaterals without any curves in this wire, and then without contrast. Sometimes, as in this case, we do test tip injection from the microcatheter to go and select which branch you can go from these collaterals. So all we know about the wires for the collateral passage, we have septal and the epicardial one. Definitely at the septal you can use cyan black or field XTR, but in epicardial we like SUHU 03 because it's a very low tip load, 0.3 gram, and it's very good for this case, for example. And if you look here, look for the movement of the SUHU 03. This is very important. You can wait for the heartbeats. This is wait and don't push because it's very fragile. At a time, and you need to follow with the microcatheter. Very important because it's a very weak wire. So you can now, if you look here, we'll be waiting the heartbeats, and then it goes to the distal RCA and the side branch. Definitely, we have a microcatheter. You can rotate some of these microcasters, and the others cannot rotate. And then you need to confirm the guide wire in the true lumen. Yes, we confirm now. We either use a test from the retrograde guiding, and then you can see and check. Then you need to cross with the microcatheter. All we know about the microcatheter, we have a septal crossing. For septal crossing, you have a rotatable microcatheter, and this is a very good microcatheter to rotate, like Corsair, Turnpike, Mamba. Or the epicardial crossing, you can use, if you have a small epicardial collateral, you can use the smaller one, like Fine Cross or Caravel, while for the bigger collaterals, CC2, so you can use a Turnpike or Corsair Pro XS. So in this case, we reach the distal cap from the retrograde wire, and then we try to do how to proceed with the wire. Sometimes it's difficult to push the wire and everything is stuck. The microcatheter is stuck and you cannot cross. There is a lot of things to do. Sometimes you need to rotate, sometimes you need to increase the support, the backup of the guiding, the retrograde guide. You can have a shorter microcaster. You can change the microcaster also different profile, and you can also antegrade anchoring, or sometimes if you are going to true, you can use this wire as a marker for antegrade. So this is how to cross with difficult crossing the microcaster. You can use, as we mentioned, this, the retrograde wire is just a marker, and this is very important to see that they are in the directed antegrade wire in front of this retrograde wire. So one of the important point is how to enter with the retrograde wire in the antegrade guide. So using how to, and you need some time to check that the wire is coming from the true lumen. So it's a true to true, and this is the best scenario. But if we look with different techniques, if you cannot go with a true lumen, we have card, we have reverse card, and we usually use a reverse card using the balloon on the antegrade wire. And this is the more popular techniques for to cross retrograde. And if we look here how to do it, we put the balloon on the antegrade as we see, and then we start to put the retrograde in the mid of the balloon, and during deflation you can try to connect with the antegrade wire or the lumen to connect it to the antegrade guiding. So sometimes there is have a problem in reverse card. So you can use either to change the target, you can use guide extension, for example, you can bigger lumen, you can direct the retrograde wire in, or you can change the balloon size. This is a very important point. If you look here, we can use, as we see, the guide extension in the RCA, and then try to direct definitely it will be easier to direct the wire in this big lumen. And if you look here, you can see how it goes for the retrograde guide extension, and then you can go through this. And then for this case, we do guide extension, guideliner for this case, and then we try to connect. If you look to the red point, that we'll see that this is the guy coming from the guide extension up to the antegrade guiding. This is an important point also. If sometimes you cannot cross in this CTO segment, you need to change the size of the balloon 1 to 1. It's very good to go with the reverse cut to create more subintimal space. And then also if you can change the wire, definitely different wires, or you can change the location of the balloon. Sometimes if you have do reverse cut inside the middle of the CTO segment, this is the best scenario, or you can use bigger balloon. If you want to use a directed, this is a conventional reverse cut. If you want a smaller balloon, you can use this is directed. It's more difficult to cross, and the extended one. But the point is the extended sometimes cause a problem if you have a side branch in the CTO segment. As we mentioned, we can change the size of the balloon. We will have a standard balloon or a special balloons, or we like to do plaque modification sometimes, intracoronal lithotripsy in some cases, and you can change the calcium, and this is compliant or non-compliant balloon. And then after doing this, you can see how it goes, and then you can try to direct. As we mentioned, you can change the wire shape. Definitely one of the important tools, the imaging. IVUS is a very good point to direct you where is the retrograde and the antegrade relation. If you have both in the intimal space, it's very good. If you have both wires in the subintimal space, it's okay, you can connect. The most difficult one if you have one in the intimal space and the other one in the retrograde space. So this is the most difficult scenario, and this needs IVUS. And definitely IVUS guidance in reverse cut is a good example to use IVUS in this scenario. In this case, we use IVUS trying to see where the retrograde. We see that this white spot at 9, this is a retrograde wire in the subintimal space, and then we try to see how to externalize our wire. There are a lot of things to externalize, but the point is sometimes you can easily grow with true to true, but the point sometimes in retrograde wire crossing, you need to look. One of the options is externalization, the wire retrograde coming into the antegrade guiding, or you can do a tipping technique. If you look how in this case we crossed this with the RG3. This is a long wire to cross, and this is how to do the RG3 wire externalization. So the wire is coming from the retrograde, and then try to disconnect the antegrade, and then try to see the RG3 coming from the antegrade guiding. And if you look how to do the tip in if you cannot cross with the retrograde. Retrograde now, microcaster is inside the tip of the antegrade guiding. We try to cross with the antegrade wire inside the retrograde microcaster, and then you can push the retrograde wire, and then you can advance the antegrade wire through this retrograde microcaster. And then you need to treat the CTO segment, as in this case, we do balloon dilatation, we do a lot of balloon and then stenting, and definitely one of the important point is to check the epicardial collaterals if there any perforation or any problem that you can see. Now, and this is the final result of that case. This is another example of another case of retrograde case with a CTO LED, and there is a good collaterals, septal collaterals coming from the RC. This is a different scenario than the other case with epicardial. This is septal, and then you try to connect.
Have 1 minute, Amr.
Okay, so you need to cross of this. You can use one of the septals, as we see. You need to choose which septal you can connect with your wire, retrograde wire, and in this case we try fail antegrade, and you look for the tip injection. You can see where is the retrograde wire. Now the retrograde wire, Gaia 3rd, is coming from the retrograde septal to the diagonal branch, and you need to externalize. We externalize, as you see, and we do in the antegrade guiding, and then this is how to do this case, and several balloon dilatation, and then definitely you need to look how is now the final result in this case, and the very good feeling of the LED after using a small balloon, and this is the final result. So one of the most important points is the recommendation for collateral passage. Please, this is based on expertise. So you need, if you're a beginner, you can start septal only, sometimes control tracking your wire. If you have more experience, you can use the septal with surfing, as we mentioned. If you have more experience, you start with the easy epicardial, and then we have more expert, you can use the complex epicardial one. So my take-home message is sometimes retrograde the only option, and so you need to, definitely we need sometimes to try antegrade, but in sometimes you cannot. And better to try surfing in retrograde, and retrograde wire escalation, hard team discussion is very important. See you in Cairo next meeting.
Thank you very much, Amr. We can.
Thank you very much about this very nice presentation, and open the discussion about the only on the retrograde, because something happened in the computer. Then later on go to the Abdallah to introduce his presentation. Any question, any comment about the retrograde CTO? Yes.
محظوظين احنا دكتور عمر الحديدي ودكتور رائد اثنيناتهم بالسي تي او. ناقصكم شوكة من العراق ان شاء الله. ودكتور عمر من تركيا حبيبي. I'm asking you, Dr. Amr, about the material and resources and the cost of each procedure and average cost of CTO intervention. Average.
Okay, the point is you have a lot of wires, a lot of microcasters, a lot of things you can use. But the point is how to minimize the cost. The most important point is you need to have some experience. If you have a go antegrade first, so you need some wires, you can definitely try to stick to one of your favorite wires. If you like to go with a Gaia, for example, or a Fielder XT, for example, you need to master these wires, because if you are not using the wire several times, you will have a lot of cost, because you cannot cross, so you remove, and then another wire, so the cost will be very high. So you need to choose 1 or 2 or 3 wires to be favorable for you to do it in these cases. Another thing is the microcasters. Also, you can use 1 or 2. Smaller one like Fine Cross or Caravan, for example, or you can use one of the Corsair or Corsair Pro as a 2 microcasters. So different you can use, and then try to avoid the cost. And definitely, if you have a retrograde option, you need to do a lot of cases. But the point is how to minimize the cost. We know all that. It's very difficult for most of the countries in our region that it's very costly. So I think if you plan well the case, as we mentioned, you don't need to do the case in the same session. in the same setting of the angio, because you need to study one. You may see another collaterals, and maybe septal one you cannot see, you see epicardial one, straight one. You can see antegrade options, very nice, and you can finish the procedure in half an hour. So the point is planning the procedure. This is very good.
Thank you, Dr. Amr.
Thank you very much, Dr. Amr. Because the problem which is happening in the computer is finished, so we start on the discussion about the retrograde later on. Let's start with the other eminent cardiologist, Dr. Abdallah, about how to manage patients with the CTO on the antegrade, not retrograde, and now the antegrade technique for the CTO intervention.
So we try to make it step by step. Antegrade now, we need to concentrate because now the antegrade almost we return back. Most of the cases, sometimes we shift to retrograde to be more than antegrade, and the antegrade now is becoming back to be more than the retrograde. So Dr. Abdallah, you have the podium, and please inform us about how to do it step by step, please.
So good afternoon, everybody. Today my talk would be about the antegrade recanalization of coronary chronic total occlusions. This is a wide title to lecture on, but I'm gonna go over and try to shine spotlights on a couple of different areas pertaining to this subject. I have no relevant financial disclosures related to this discussion. The aim of this lecture would be to present a contemporary and instructive review of the Antegrade CTO PCI, which is one of the most exciting frontiers in adult cardiology. This is one of our presentations down in year 2013, when we reported a success rate of 67% over 2 years on a cohort of 2,050 patients. Of course, the success rate increased from 50% in the year 2010 to 81% in the year 2011. And that was because of performing less ad hocs, providing extra time allowance for operators, using more specialized devices, enhancing second attempts, and performing retrograde techniques. Now we come to the CTO, how it is defined. It is defined when a clinical evidence of coronary occlusion is present more than 3 months, and there is zero flow at the site of obstructed segment. It is certain when there is a previous angio, and it is likely when there is MI older than 3 months, and it is probable when there is stable angina more than 3 months with suggestive anatomy. When we talk about the pathology of CTO, we can find microchannels in around 40% of patients, and of course this would increase the success rate of recanalization, and we'll find homogeneous hard plaques in the rest, which is associated with lower success rates. Treatment of CTO by PCI have prerequisites. We should not perform these procedures left and right. The prerequisites are symptoms, viability, evidence of reversible ischemia, and the presence of useful collaterals. Ever since 2017, the year 2017, the indications for revasc in ischemic heart disease are determined irrespective of whether the lesion is a CTO. The indication for revascularization of a coronary lesion, whether CTO or severe stenosis, is based on symptoms, ischemic burden, and resistance to optimal medical therapy. With 20% of all patients undergoing coronary angiography having one or more CTOs, and around 20% of all CTOs approached by PCI only, the challenge for modern cardiology is to streamline the technique and expand the training on revascularizing the CTOs. Why the CTO PCI is not frequently attempted? Because of lower success rates and the perception of increased risks. The adverse factors are lower success rates, longer cases, more radiation exposure, more resource utilization, and the incidence of potentially catastrophic complications. Now, several scoring systems have been developed to determine the likelihood of technical success and the potential difficulty of the procedure. And these scoring systems are very useful for the beginners in order to time the length of the procedures and so on. This is the hybrid approach, which was set by a number of US physicians, in where they suggested 4 strategies to tackle the CTO. 2 of them are antegrade, the antegrade wire escalation and the antegrade dissection reentry, and 2 of them are retrograde. They recommend applying the antegrade as well as the retrograde interchangeably, and they believe that doing retrograde after long antegrade cases are outdated. Of course, this is in here a dual injection. Dual injection is very essential to clarify the lesion of CTO regarding the length as well as the vessel course. And upon this dual injection, of course, we can determine whether the proximal cap is ambiguous. We can determine the distality of the vessel, whether it is adequate or not, and we can determine the adequacy of collaterals and assess the length of the lesions. We have to study the CTO. We have to look at the proximal cap, at the distal cap, and as well as to the collaterals. We have to address many predictors for difficult crossing, including the calcium, the tortuosity, the absence or presence of a stump, the length of the lesion, and the presence of a branch at the CTO. Further clarifying the options within the algorithm, the hybrid algorithm, the core in this is stable, but the scope is expanding. We can see that in some patients in the middle of the slide, we can see that these patients, they do not qualify for an antegrade. At the same time, they don't have good interventional collaterals. So we have to start the antegrade and try to do antegrade dissection reentry, whether IVUS controlled or whether by knuckling. This is another algorithm suggested by the Asia-Pacific algorithm. And it emphasizes the guide wire usage rather than devices, mainly, together with IVUS use. The antegrade wire escalation and the antegrade dissection reentry are integral parts in all stages of learning. It is present in stage 1, 2, 3, and 4, and it is essential that the operator, any operator on CTO, knows well all the details of those strategies. General concepts, no ad hocs, that's a big no-no. Put your plans up front, and you cannot assume doing a CTO PCI on the fly. Success needs training, expertise, technology, as well as patience. When you persevere, you can do anything. Should have a modern cath lab administration of the hospital should be supportive because the toolkit is expensive, and you should encourage a hard team collaborative approach and to work in a switched manner with a colleague if possible. Respect the failure of others, especially when you have referrals, and publicize the success rates. Always be ready to face highly combustible situations, complications, and sometimes you may run out of all tricks, but even though succeed because it's a matter of luck rather than wisdom and science. Never compromise on safety, this is very important, and several knowledge gaps are present in CTO PCI, and from my own experience, the results are not so reproducible as in structural heart interventions. The radial versus femoral approach in CTO PCI, the vascular access is upon the discretion of the operator. However, in complex CTO PCI, the success rate with the radial is significantly lower than the femoral. Using at least one transradial axis was feasible in some registries. However, they were associated with longer fluoroscopy and mean procedural time. With regards to the guiding catheters, they should have soft tips with large internal diameters with no side holes, especially in the donor arteries, and they should be supportive, as pushing on the hard cap may kick off the guiding catheter. Amblets and XP are usually preferable. Long femoral sheath, 7 French is better than 5 or 6 French. Femoral is better than the radial. EXA support wires and body wiring are necessitated in several procedures. Mother and child guiding catheter extensions are needed sometimes, and side branch anchor technique is a last resort to increase the support of the guidings. Side branch anchor technique, you can see that many times we can support the guiding by ballooning a side branch, and this is a balloon crossing become possible only after the side branch anchor. Regarding the wires, the threshold to exchange the wire should be less than 5 minutes. You should not stay trying with one wire for like 15 minutes or 30 minutes. You should always exchange and try another wire. Polymeric adds on the lubricity, and their main use is tracking. And the coils, they are there for control and tactile feedback. They inhibit or decrease the whipping, and they can provide us with one torque. Other properties of the guide wire that are needed is that they should have a good tip load, and they should be supportive. Soft plastic spring, non-polymeric, non-tapered workhorse wires. If one cross with any of these, the legion most probably should not be a CTO, like BM wires, Cougar, Zinger, ATW, Samurai. If you succeed using one of these wires, then the legion is most probably is not a CTO. The wires which are used in CTO are usually polymeric or non-polymeric. The polymeric are used for crossing microchannels and create knuckles, and the non-polymeric are used for penetration. Of course, some of these wires are tapered and others are non-tapered. Regarding the XTA and XTR, the XT family, they differ in the tip load. Their tip is like 0.009 inch, and they have a composite core which help in the trackability of these wires. The Asahi XT, Scion, and Gaia wires, they have, all of them have a composite core, which include the central core, the Act1 core, and the twist core. And these cores help in shape protection, torque transmission, as well as negating the whipping phenomena. This is to show how these wires can prevent, the composite core can prevent the whipping. You can see on the left side hand of the slide with a Sahi sign that the wire does not whip, and that the torque accumulative core rotation does not accumulate, while on the right side hand you can see how the other wires can
1 minute, Dr. Abdallah. 1 minute.
Okay. This is the Gaia wire, and here we can see that it is used for directional control, and it can help as an intermediate polymeric tapered wire in many CTOs. You can see that in the contrary, as opposed to Confianza and Conquest wires, they deflect to stay in the lumen. Both of them are stiff. And this one in here shows how the Gaia can, the tip of the Gaia can be fractured inside the body of the CTO. And this is to show the key features of the Gaia Next, which are now available in the market. These are more torqueable and have higher penetration force, and the tip load also is higher than the old ones. The wires that are more suitable for knuckling in case antegrade dissection reentry is needed are the XTA Gladius, the Gaia 2nd, and the Pilot 200. Of note is that the Gladius can make small knuckles, and the space in here, the subintimal space would be small, and it can mimic the same space that is created by the BOSS device.
Would you like to conclude, Dr. Abdallah, please?
Okay.
You conclude? Please. Thank you very much. Thank you very much if you conclude.
Thank you very much.
Thank you. Thank you for listening. We can do discussion after. The discussion after. We will do the discussion after we finish here. We'll keep 5 minutes for discussion. Thank you.
Okay, the last presentation today about the CTO. The CTO of ambiguous LID ostium is presented by the Dr. Raed Alawaisheh. Please, Dr. Raed.
Thank you very much for giving me this chance. After you are loaded now with the Antegrade and Retrograde, I'll try to show you examples, especially one of the most difficult situations when you have an ambiguous ostium of the LAD. So I'll give you 2 cases, one succeeded with one Antegrade, one succeeded with Retrograde. This is a 48-year-old gentleman who had for 6 months angina after having MI, and the double injection single cine technique, as you can see here, that you can see the OM, and here is the RCA. And the LV function, as you can see here, that the LAD area is viable and functioning well, and despite that, the LAD area is really almost, the LAD for a long segment actually is occluded. So the first trial, just to go with the wire and the microcatheter, as usual, I succeeded actually to go with the entrance there and finding the LAD, followed it with the microcatheter, but unfortunately the wire is far away from the LAD, so there's something problem there. So I shift the approach to the retrograde approach. You can see here that the epicardial collateral is really long one and really tortuous one. So you need a special wire to go with that, with the microcatheter, and as shown by Dr. Amr, how to go with the SU wire and wait for the heart to take the wire step by step, small curve by small curve, and then you follow it, and I'm there in the LAD. Unfortunately, something happened and not to give general anesthesia for this patient. and he pulled everything out. So I regret there, and we stopped. We did not continue with the retrograde, so I decided to go with, I will not go again with this retrograde. So I decided the next time to do CT and find out why the LED was not easy in the antegrade. And you can see and appreciate very well here by the CT that there is a significant tortuosity in the vessel. So this is when you go with the side-by-side view of live fluoro and the core wave. So this is will make it easier for you to go with the antegrade. This time, I prepared myself very well. I get the IVUS and the penetration guided, IVUS guided penetration of the ambiguous LED, and using the supercross microcatheter where it can, this is with curve, so it can go with the wire and do the penetration to the proximal cap, and from there go to upscalation, downscalation, changing the wires with the microcatheter, because it is tortuous vessel, so you need to mix. And definitely you will need to use the ADR technique, the anterior dissection re-entry technique, so you'll be able to overcome the tortuosity in the LED and making your microcatheter following the wire. The problem actually with the ADR is the re-entry, as you know, and the re-entry you have many techniques actually to go there, and here I faced the problem actually with getting the re-entry, so I get the two wires or two parallel wires technique. This has failed, so I used the dual lumen microcatheter to go for the penetration, one penetration wire, one direct wire, and in spite of all of this, it was really unfortunate. I was not able to find the true lumen, and hematoma start to be there, and you can see that the what left from the LED is really a small segment. And unfortunately, I don't have Stingray in that cath lab that day. So I regret there and stopped there, and not to lose what I did and lose half the job, at least for the ambiguosity of the LED, I planted the stent, and the stent implanted there, so when I returned back after 1 month, I can find that the hematoma resolved distality and easy to go from the proximal or from the ostium of the LED. And this is what happened. After that, you go with the wire upscalation, downscalation, you can see the curves there. And I shifted from the polymeric to the penetration wires, and successfully went there, and we opened it by the antegrade approach, and stented nicely, and this is the final result. So the conclusion actually from this case, actually for the CTO operator not to be stubborn and stuck to antegrade or retrograde, and be very flexible actually of changing from side to side, or from the technique to the other technique, keeping in mind that you are well prepared by skill and well prepared by your tools. My second case actually is another case, interesting case for a patient who had also a CTO on the LED, and as you can see here by the injection from the right side, you have dominant RCA, but nothing, almost just a shadow there in the upper of the skier, in the corner of the skier, you can see something is filling there, but you cannot appreciate a real LED vessel. So getting the left system, and you can see here the circ, and you can see the OM, and you can see a branch there going up toward the LED, but till now I cannot find an LED or proper LED. Maybe there is some ramus intermediate, some branches, and ghost of a vessel there. So as you can see from here that the CERD giving the OM, and the OM give an epicardial collateral to a diag or branch, or just collateral there, but still till now there is no LED from the ostium. So I went there blindly to go with the LED by the antegrade approach, trying to open it, which is as expected, it will fail. So I want to change to another approach, was to go with the retrograde from the same side, from the left side, the ipsilateral side. So I go with the wire, and you can see here the wire in the OM, and trying to go from the OM to the epicardial collateral there. Use the microcatheter, use the caravel microcatheter, the cyan blue, you go down as much as you can. Once you have resistance to the cyan blue, it is time to use the SU03 wire. And to facilitate the things, you need to go with the microcatheter and to give the microcatheter injection at the site that you want. And as you see here, using the microcatheter injection will explore for you the road very well, and it will eliminate at least the other branches and the other collaterals. So it will be easier for you to go and use the SU03 wire and waiting for it slowly, beat by beat, and it will take itself up just by slide support, not to push the wire. Actually, we are pushing the microcatheter behind the SU03, because each wire, you need to know, when you go as a CTO operator, you need to know each wire, how it works. For example, for SU03, we don't push the wire as much as we keep it to go with beat by beat and allow the microcatheter to support it. The opposite, for example, for the penetration wires like Gaia wire, we have the torque 1-to-1 and penetration. So you need to know each wire, what it is used for, and how to use it, and because you know the wire character and how to do it. So that will make the things easier, and the most important point, not to make it just easier and to cross, also to avoid the perforation, the dissection, and the problems to go there. So as you can see here by this wire, it went there to the diag, successfully reaching to the LED. And now the other challenge actually is the proximal cab, and to go from the LED or to reach from the diag or the LED or whatever vessel there, and then to reach to the left main, because it's ostial LED, as you know. So you need to explore your way again, and you give the microcatheter injection. Don't hesitate to doing the microcatheter injections, because this will give you lots of data. As you can see here, that this is, so now I know that this is diag, and the other branch that appears there is the LED or the ghost of the LED. And we go from there, and as you can see that the wire, I changed the position now to take the codal view. This is the OM, and the LED now is up in the screen there. And giving the microcatheter, you can see the injection from there. So I know now I need to go with the wire. I hope this is working. Anyhow, try to go with the wire now toward the left main and toward the guide. Changing from the caudal, and don't be stubborn just to fix your guide catheters, or you fix the screen in one direction, you go with more than one direction. After externalization, this is successfully, the wire went there. Now you need to take the end of the wire from the left main, and this is the way. Is the laser working, the pointer? Is it the middle or not? Oh, okay, thank you. So as you can see here, I hope you can see it. The microcatheter, actually the tip of the microcatheter is here. So you need sometimes to explore, or to externalize not only the wire, because this is the epsilateral technique, and you need to go with the ping pong technique. So it's better to go with the microcatheter down to the aorta there. So it's easier for you to get the wire there, and from there to try to go to the tip of another guide. And when you go with the ping pong technique, it's preferable to use another guide, another shape. For example, when you use the EBU for the Antegrade, you use the left Jotkin for the Retrograde. So this will make another direction for another ostium of the catheter. So you can go with the wire there. And this is what I'm trying to do. As you can see here, that I hope. If you concentrate there, you go with the wire and try to get the wire inside the wire. So this will be your retrograde direction. And as you can see here, successfully the wire went. Trying again here, supported the microcatheter, changed the direction, and taking this view, you can see now the wire still is not getting. I hope this one maybe? No, this one actually we show it very well. Go back. And here, getting the wire inside the another catheter, and then you do the externalization. I hope to slip now. I hope that it choose the right view. There's long one, but at the end of the day, the wire went in. You need some trials. I think now we are in. As you can see here now, the wire is in. So this wire needs to be exchanged. So you go with the microcatheter inside the retrograde catheter, and you change the wire that you used with the RG3, which is the long one, so you can externalize it. And from the tip of the wire, which is the RG3 wire, which is externalized, I go into the balloon and dilate toward the LED. And now I can now exchange the wires by using the microcatheter and getting the LED wires. Now I have the Antegrade. Now it becomes easy. You need to exchange it over the microcatheter. And to keep the side branch. It is very important nowadays to keep the side branch, because even it is related to the mortality after doing the CTO operation. So now we have the wire in the diag, and also the wire in the LED, and dilation, the usual way of stenting, professional stenting even I did in this case, and it was, I think it was successful PCI. And you see the ostium of the LED. So this is the two examples of two cases where Antegrade and Retrograde used for the ambiguous LED. And this is my simple conclusion actually is when you do CTO, it is very important, as Dr. Iyad mentioned, sometimes you need to do the intervention. It is more proper than doing the aggressive medical treatment or giving the patient the aggressive medical treatment, and to keep the side branch and to keep the CTO simple, having all the techniques. And I hope you enjoy the two cases. Thank you.
Thank you very much. Now open the question. Yes, Dr.
In the second case, I think I was not sure how you go with the Antegrade gear. Because I mean how you punctured that ambiguous cap. But many times, just to clarify this very important point, that with such an ambiguous, it is not certain where is the cap in this second case. So you have to have IVUS in order to see where you can puncture antegradely. The second thing, when you want to make a communication, it is better to be sure 100% that the communication is far beyond the ostium, in order not to compromise the circ, or to go into the subintima, or into the aortic wall. So I was not sure how did you puncture that cap, and how you make the connection in between the retrograde gear and the antegrade gear.
Yes.
Yeah.
Actually, you need to modify the technique according to your point. If I'm not sure, yes, even when I use the penetration wire, stiff wire, this is absolutely right. You need to go with the IVUS and all of these things. If you notice here, I use the polymeric hydrophilic wire. Once I reach there, because I used to, this is my strategy, go with the upscalation, downscalation with the wire. This wire, if you saw after the penetration, the wire was able to go to the circ and was able to go to the left main. So going in the two direction easily without any resistance, the hydrophilic wire, means that I'm in the true lumen, because there is no way actually to have the wire freely moving in the two directions unless if you are really in the true lumen. I agree with you 100%. To use the intravascular imaging is an essential thing in CTO and making every step. Sure, I agree with you 100% to do that. But sometimes, okay, when you have everything is there, so maybe I can skip that.
Sorry. Any comment or question from the
Yeah, actually, I think you had very great cases, Raed. Just in the first case, you decided to go through the epicardial vessel while you have tiny septal collaterals. I think that sometimes maybe you tried to go through the septals because it's more safe, it's shorter. Sometimes the guiding catheters and the microcatheters are very short for this very long epicardial vessel. Yeah. So you finished with a good result in the ostial LAD, but still we have a dissection which was subintimal, and we lost some maybe of the vessels. What do you think about the ADR in this situation? You know, you did the ADR almost, and about the results for the long-term results in this situation.
Yeah. In this case, if Rami Habibi, if you noticed, the segment which is really seen from the LAD is just at the apex. It's a very short segment. You cannot see the body of the LAD from antegrade or retrograde. Only from the epicardial collateral you can see the LAD. So that's why it was not sure. There is no septal connection actually between the RCA and the LAD. That's why I choose this epicardial collateral. And the second point about the ADR, this is what I'm against with the ADR. If you are able to do ADR without losing the side branches, yes, this is absolutely better than doing the ADR. It is without losing branches is the ideal thing to use the ADR. But as you know, most of the time with ADR you lose the side branch. Keeping it is really an essential. In the second case, you saw how much I was very conservative and to keep the YAG there and not to lose it. So the ADR, the enemy of ADR actually is losing the branches.
Thank you.
Okay. Yes, sir.
Thanks, Raed, for the nice cases. I have first one comment. Why don't we use coronary CTA as a guide map routinely done before any CTO? That will help in solving some of the issues that you might be surprised during the case. That's number one. In your case, when you parked the LAD stent, when you failed in the first attempt, that's something I'm not used to. I never seen it before. And it carries really big risks. Yes, you marked it, but this is a stent with no distal flow, close to the left main. Was that a worry to you?
This is actually, I have learned it from Werner and from Maximiliano. They used to do this, and it is very safe actually that you are sure that the wire is in the subintimal space and your stent is not in the true lumen, it is in the subintimal space, but it's a marker for the ostium, not to return back and to do all the steps that you did, because this you will postpone to another procedure or another step, another stage after a while of time, 1 or 2 months. Actually the thrombosis, it will not keep the patient in antiplatelets therapy. It never happened actually to have thrombosis in this. Inside the stent, yes, definitely it will be included because there is no flow, but it is just as a marker and not to return back everything from the beginning. And the CT actually is very important to do it as strategy, but it is not usual. Even by the guidelines in CTO to go with the CT, it is not the recommendation of 1, it's a recommendation of 2. And doing the CT actually in some cases, when you have a long segment of occlusion, and especially if you want to stage the cases, yes, definitely CT will be important. But if you are a CTO operator and you did the case and you find that you have a CTO and it is the only one to blame, and no another culprit lesion, and you want to start with it, you don't have CT, you go ahead and do it.
Okay, as regards the CT, it's very important to see that it's not a routine CT in every case, CTO, definitely as you mentioned, but the point is when you have long lesions, calcified, and you don't know where to puncture, anti or retro, and when to prepare yourself. This is why how to plan your procedure before you do the CTO. Because if you don't plan, especially in these scenarios, so you will have a lot of problems. CT will help a lot to lower the course, especially if a tortuous vessel, for example, the RCA was a very tortuosity, not a straight vessel. Number 2 is that imaging is very important when you have a retrograde with a very short ostium, LAD. But as you mentioned, the wires crossed in the left main and the circumflex is assured that you are in the true lumen.
Yes. ambiguity actually in the LED by CT or by IBUS. It is not that optimal. It is not that good. You know, even you have CT, you know where is it by the CT. When you go inside the cath lab, it's very difficult actually to match it. Even when you give the screen by screen, I find it really difficult, and most of the CT operators find it difficult.
Thank you very much. My question to Dr. Abdallah about the retrograde.
Yes.
What's the criteria of the lesion when you start from the start? Sorry, Dr. Amr, for the retrograde. Sorry.
Dr. Amr?
About the criteria of the lesion of the CTO to decide that it's from the start you begin to retrograde, not antegrade.
Yes, this is a very important question. The first thing is that especially have an ostial lesion, flush ostial lesion with the aorta. This is a very important point that you need to start retrograde. So you cannot go antegrade. Number two is if you are not sure with very long lesions, as in some cases, and you cannot decide where to go for the antegrade, you will go a long journey to go antegrade to reach this very long lesion. So sometimes we can use the retrograde wire as a marker. You can complete the case antegrade, but the point is you need a marker to be sure that this is the connection. Will be the lumen that you can connect. Number three, definitely failed trials, definitely from antegrade with an expert procedure, you will start retrograde. So this is the important 3 points that you need to start retrograde.
Thank you very much. When the time is over, thank you very much for this nice presentation.
Thank you very much. Thank you.